Hello and welcome to the podcast. Today I have the immense joy of having Dr. Mariela Glandt. Dr. Mariela Glandt, thank you for joining and accepting this interview. For those who unfortunately do not know you yet, could you please introduce yourself and your practice?
Sure. Let's see. I'm an endocrinologist. I trained in the U.S. I'm originally from Argentina, and then trained in the U.S. Um, at various places, and including Harvard, at Beth Israel, where I did my residency, and then at Columbia, where I did my fellowship.
The top places, huh?
Well, they're good, and they kind of made me think that I knew something. Then to discover that I had a lot to keep learning. And then I actually worked in private practice a little bit, but also in the Bronx before I moved to Israel, married an Israeli, moved to Israel, and worked, I don't want to make this too long, but I ended up actually building my own private practice there, which was a really amazing opportunity to practice on my own, meaning that when I did discover the low-carb movement, I had freedom, which was a very important piece of this puzzle, because I was able to practice, what I wanted to practice without people above me telling me what to do. So, this is kind of what led to my whole development of really going down this path about 11 years ago, where I really changed the way I practice completely. And today I am the CEO and founder of ONA Health, which is a diabetes reversal clinic, a virtual diabetes reversal clinic, really focused on the underserved population in the United States.
Okay, nice. Okay, so before we move forward in this interview, sometimes I feel that, of course, people who are suffering from diabetes, they know a lot about their own disease, as they have to understand it. But unfortunately, I also noticed that too often that most people who are not diabetic themselves are quite unaware of what that metabolic disorder and its negative effect on someone's health could be. So could you please briefly recall the viewers what really is diabetes? What are the differences between type 1, type 2, and how type 2 diabetes develops, and what are the practical consequences on someone's life?
Okay, that's a lot of questions. So I'll try to break it down.
Yeah.
Okay, so first of all, we have to distinguish between type 1 and type 2 diabetes, because people sometimes get confused. And type 1 diabetes is basically the opposite of type 2. In type 1 diabetes, you don't have enough insulin. Your beta cells are destroyed by an autoimmune process. It's a process where the body destroys the cells that make insulin. And this leads to a lack of insulin. And therefore, since insulin is the hormone that brings sugar from the blood into the cells, and it does a lot of other things that we can talk about, the symptom is an increase in blood sugar. And that's why the treatment for type 1 is insulin, okay, which is an easy thing to say, but a very complicated process. But you replace the insulin, and then the problem is solved in a way, okay? Of course, again, very, very complex. But type 2 is actually the opposite. In type 2 diabetes, if you measure the insulin levels are high, okay? What that means is that there is a rejection. The cells are trying to protect themselves from too much insulin, and the receptors for insulin are downgraded. They're less receptors for insulin. And therefore, if I eat something with carbohydrates, say a sandwich that has bread, the bread becomes glucose in the blood. The pancreas releases insulin, and now the insulin doesn't work. Okay, so that's called insulin resistance. It doesn't work, and we can talk about why that is. It's very, again, the whole world, but the insulin is not working. And therefore, okay, I need to secrete more insulin. The pancreas needs to secrete more insulin to overcome this resistance. Now, sugar in the blood is diabetes. So the pancreas, as long as the pancreas is healthy, it will secrete as much insulin as needed to get that sugar down.
Yeah.
Okay. So type 2 diabetes develops when the pancreas can't keep up. And then I have high insulin, but also now high sugar. Does that make sense? So that's type 2 diabetes. So you have a combination of high insulin and high sugar. But to understand type 2 diabetes, you need to understand that the first problem is the insulin resistance. And type 2 diabetes is an insulin resistance manifestation. It's a symptom of insulin resistance. We have many others, right? Like high blood pressure, low HDL, high triglycerides. The list is very long, but one of them is type 2 diabetes.
And can type 2 diabetes become type 1 at some point?
Not really, because they're different mechanisms. You may end up needing insulin, but for different reasons, but it's not type 1. So you end up needing insulin, but not to confuse the two pathophysiologies.
Okay. So you've been an endocrinologist for decades now. What would you say when it comes to an epidemiological trend? Is the incidence increasing? Is the median age at diagnosis decreasing? And what about type 2 diabetes in teenagers?
I mean, that's everything that you said is yes. The answer is yes. Okay. Yes, type 2 diabetes is still increasing. Yes, the age at which we diagnose type 2 diabetes has gotten lower and lower. And people very young are starting to develop type 2, which was always considered like a disease of adults, a condition of adults. And now we have really an epidemic. We are in an epidemic where, and this is worldwide. The US leads it, but China is also there. The Middle East is there. India is there. And Europe is lagging behind. But if they continue to do what America has been doing, they will catch up. So
what would be the cause of it?
I mean, the cause, I think, is an environmental cause. There used to be no diabetes or very rare diabetes 100 years ago. Very rare. Now everybody has a cousin, a friend, somebody with type 2 diabetes. When it was something that was a very rare phenomenon 100 years ago. Now, many things have happened in the last century. So it's really hard to pinpoint exactly. But my feeling is that it's not just a feeling. It's, I would say an educated guess, is that this is really the result of two major things. The incredible addition of sugar to all foods. Okay, in the United States, about 88% of foods have added sugar that you buy in the supermarket, of the products that you find in the supermarket. And this is completely changing our metabolism. So while we were able to handle simple carbohydrates like rice and pasta, rice and pasta and yams and vegetables like grow below ground, what's happened is that we have changed our physiology, because fructose, which is sugar, that it's the type of carbohydrate that tastes sweet. Okay, fructose is what gives it the sweetness in your mouth, and this actually is a relatively new phenomenon since slavery. Before that, we didn't really have much access to fructose. There was like fruit and honey, but very difficult to come by honey back then, and fruit was only in season. And now, okay, we've really flooded our food supply with this ingredient, which really does not function in the body like other carbohydrates. And secondly, we've added industrialized oils, which were also not part of the diet. So I think the combination of these two things have hijacked our system and have made us really sick. So then I will just add that in order to reverse disease, I have to take out all the carbohydrates. So while carbohydrates in and of themselves are not a bad thing, okay, such as we saw in China for thousands of years, then, but then when you add the sugar, it just really shifts the whole dynamic in the body, the whole physiology. So I would say, in my opinion, these are the two leading factors. There are many other components that affect metabolic health. But in my mind, these are the two that are most significant.
So I heard Dr. Gary Fettke, sorry, Dr. Gary Fetke spoke a lot about fructose. You mentioned fructose as well. How does fructose impact the development of diabetes in terms of physiology?
Well, fructose doesn't need insulin in order to get into the cells. Okay, so hey, it looks like, oh, that's pretty cool, right? Like if it's like an easy way of absorbing energy. The problem, there are lots of problems with fructose, but first of all, fructose can only be metabolized by the liver. And actually, processing fructose leaves you depleted of energy. It actually, instead of making ATP, it consumes ATP, our our currency for energy, and leaves us more tired. Okay, that first of all. Fructose then also very quickly becomes fat in the liver. And when you have fat in the liver, that liver becomes non-functional. And this is like basically a very big component of metabolic disease. So once you have a non-functional liver, things start to go awry. I mean, it's not a completely non-functional. There are different parts that are affected differently, but one of the core things that you find in type 2 diabetes is fatty liver, and fructose has a lot to do with this.
Mm. And do you feel that liver disorder is addressed properly?
Oh, no, absolutely not. Okay. Most people don't understand that fatty liver, okay, is a clear sign of insulin resistance, and that the solution is to take away the fat. I mean, sorry, just I said the wrong thing. It's to take away the carbs. People think that you have to stop the fat. And that's exactly the opposite, right? You think fatty liver, oh, I better stop fat. No, exactly the opposite. You have to allow the body to burn fat. And you can't burn fat if you're eating a lot of carbs. So in order to burn fat, I need to get the carbs out, and then I allow the body to burn the fat, and then the fat disappears. It's really quite...
I feel like for the past, I don't know in the US, but as a European, I see it from maybe 15 years, more vocal advocates for low carb, keto, and everything. But still, this idea of eating more fat in order to use fat as an energy is still difficult to get in people's mind. Huh?
Oh, yeah. But you have to be careful, right? It's not just about adding the fat. You have to add the
Right.
fat and take away the carbs.
Carb, high carb, low carb.
Right, right. That it's that combination, right? Because
It's still difficult because I see many people, they want to start a low carb and they start and they understand I'm going to reduce sugar, and then after 3 weeks or months they crash in terms of energy, and they say, well, I did everything you told me. And I said, what about the fat? Oh, I can't eat much fat.
You're right. It's hard for people to eat fat. Yes, it's hard.
Is it physiologically? Is it psychologically? What do you think?
I think it's both. I think it's both. And also physiologically, we don't have, let's say, we have a lot of satiety that comes from eating fat, right? So some people feel that right away, and some people, but yes, you kind of have to learn how to eat fat.
Okay. So when it comes to treatment, I feel that for a lot of people, including MDs or health practitioners, type 2 diabetes cannot be reversed. It can only be managed through medication, to which Dr. Glandt is saying,
Wrong. That is what we learn. So, I definitely don't blame doctors for thinking that. That's completely, I realize that that's not true, that once you have a diagnosis of type 2 diabetes, you're not stuck with it. There's a lot you can do. You can actually get rid of it, but with the right advice. And I think this really invigorated me to get this message out, because it's a very difficult diagnosis that is highly associated with depression and with, decreased quality of life. And there's no reason why people should die earlier with this diagnosis. And all we really have to do is is get the nutrition right. And that sets the stage for many other positive things. When people eat this way, they have more energy and then they want to go to the gym. When they have more, they sleep better. A lot of positive things come from just changing the diet. So that's why I put so much emphasis on the diet, because it's the easiest thing to do in a way. If you ask somebody who's type 2 diabetic to go to the gym and start exercising, well, they're hoarding energy right now because they have high insulin. So high insulin is trapping their energy in their cells. So they don't have the energy to go out and exercise. But what happens is that the more you're consistent with the diet, suddenly that changes and you are now invigorated and ready to exercise. And I love it when patients come to me like 6 months into the diet and they're like, I want to sign up for a gym for the first time in my life. I'm like, yes, we're in a good place, and that's exactly how it should be. So that, energy expenditure starts to go up. And in all the other diets, when you starve yourself and you eat less and move more, energy expenditure goes down. So you are more and more tired instead of more and more energized.
So what would be the percentage of your patients that actually reverse a common type 2 diabetes?
Well, I think it really depends on the definition, right? Remission, I think, is the more accepted term. Has a lot of definitions. It's drug free for 3 months, and then with a normal A1C, or does it have metformin or doesn't it? And there are many ways to look at this. Actually, in my mind, I'm talking about reversal, meaning I'm improving while taking away medications. This is kind of how I see it. Like the path reverses. Instead of getting worse, which is what type 2 diabetes does, type 2 diabetes, if you keep eating the way you're eating, it will always progress. It's true. It's true what the American Diabetes Association says. If you continue doing what you're doing, you will get worse and you will need more and more medications. Has been shown many, 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 many times. So the path to treatment is just add in something else and then add something else and add something else. But, as we talked about before, we don't have to do that. To me, reversal is let's start peeling away those medications, deprescribing, and seeing your glucose improve. So that's really what we do. So I don't actually have a number. I have to go back and look at exactly at the reversal, at the remission rate, if that's what you're interested in. Yeah. But in the Bronx, we have 60% of our patients get off insulin within 3 months as their sugar improves dramatically.
Okay. That's the thing. I think that's what Dr. Jason Fong was saying in his book, Diabetes Code. He was saying like more you take insulin and more actually the disease gets worse long term.
Exactly. That's the irony, right? Like we're giving patients insulin, but it's just actually accelerating the progression of the disease. It does lower sugar moment for, right there, right now, but it doesn't really cure anything. It increases the weight gain. It decreases the energy. It just, we already have too much insulin to start off with. So adding more insulin is not the treatment.
But I don't know, I'm still very surprised that I'm not a medical doctor. I can read this book, understand that easily. And you still find doctors who are just going with it.
I mean, everybody, this is how we treat type 2 diabetes. When diabetes is under control, we usually add insulin. This is what we're told.
But it's easy to understand that it will get the patient in a worse position.
Yeah. This is not something that I was ever taught. Although I have to say that I was taught that insulin causes growth, right? So I remember I had a teacher that said, you want to make something grow, add insulin.
Yeah.
But then we walked into the patient's room and we prescribed insulin 4 times a day. So there's like a disconnect between what we say and what to the patient and the science. Because, we know that insulin is involved in plaque formation. We know this. We know that it's the number 1 risk factor actually for cardiovascular disease, and it's an independent risk factor, even when you look at all the symptoms.
So the plaques can also grow through insulin.
Yes.
What was the piece of information that triggered you to go from the conventional knowledge to, oh, that sounds interesting and maybe sounds also right?
It was a combination of things. Yeah, a combination of things. I have a friend, Jessica Apple, who really kind of helped me to push me in this direction, and Sam Apple, her brother, who both got this early on. And they're not doctors, which is helpful. And then, like you said, I started reading. Well, really, it was the Sarah Hallberg video, "How to Reverse Diabetes by Ignoring the Guidelines," that really hooked me, and that just blew my mind. And then I very quickly got to Jason Fung and many other people who we're a limited number here, although the literature is growing. And I just, my life was turned around, because I couldn't believe that I didn't know this.
But among your peers, do you see a growing interest towards the low-carb keto approach into diabetes?
Not fast enough. Not fast enough. I still can count in one hand how many endocrinologists I know that actually practice this way. Yeah.
On one hand. Wow.
Yeah.
Oh, I wouldn't believe so. I thought by now.
Maybe there are others. I'm sure there are others. I just don't know them. But as far as endos are concerned, yeah, I know very few.
Okay. There was one, I think, thing that I wanted to ask you, because I fear you only know you're diabetic when it's too late, right? So as type 2 diabetes builds up over years, as you explained before, what would be the silent symptoms or expression of the disease that people should pay attention to before they get officially diagnosed?
No, it's quite simple. Are you developing a belly? Okay, pay attention. If you're developing a belly, you're probably developing insulin resistance, because what it means is you ran out of subcutaneous fat space, storage space. So you don't have space to store fat in where it should be stored. And then you start storing it in visceral areas, and that's really the belly fat. And that's a very inflammatory organ, that this visceral fat that releases a lot of cytokines, and that really sets up the stage for type 2 diabetes. So this is you don't need to go to the doctor. You just need to look in the mirror. If you're developing a belly, go low carb, get rid of it. Give your body the chance to burn that belly. And you burn that belly by taking away the carbs, and then you kick into fat burning mode. That's it. So this is really the easiest way, cheap, requires no lab testing, doesn't even require checking your blood pressure. Okay. But if you check your blood pressure and it's elevated, or you do get labs tested, first of all, your triglyceride to HDL ratio will tell you if you're insulin resistant, because this is a very cheap and easy way of testing in the lab. But also you should ask for an insulin level, because a fasting insulin level that's more than 4, in my mind, is already like, wake up and understand that even when you're not eating, insulin is elevated and you're storing fat. So that's a very easy thing to check. And then you have your eyes wide open.
Okay. All right. Would you say there is a difference in how patients experience their condition when they go through, let's say, purely pharma-driven treatment versus a low-carb keto lifestyle changes? In a sense that, does the low-carb lifestyle give patients back a sense of control and therefore renewed hope when it comes to their condition?
Yeah, that's why I love my job. It's just like people are grateful. They feel in control. They feel like they can say no. I mean, GLP-1s do that as well, as give patients back the control. But it's so nice when it's endogenous, when it's an internal uh, and a feeling of like, oh, I'm in front of a dessert table and I'm actually able to say no because I can, not, like there's something like I am able to resist this. And that's an amazing feeling. And this is coming from the changes in the hormonal changes in your body as a result of the diet. So this is really a therapy more than a diet. It's actually a medical therapy, what we're offering patients. But by the way, we're making a lot of other things happen, which is not just improving your diabetes, but your mental health. Depression goes down, anxiety goes down, pain that goes down. There's so many other good side effects to this diet. So this is something that we can really, it's really empowering, and patients are extremely grateful for it.
So, what should we understand about the GLP-1 drugs like Ozempic, Wegovy, and others? Like, in your view, who should be using them and how are they best used? And what would be the concern when it comes to the side effects?
Well, look, I have been prescribing GLP-1 since 2005. Way back then, because I had a private clinic, I had the patients, they wanted Victoza and they got it. Okay. So I really got to know the GLP-1s up front and up close. And actually I did many clinical trials with GLP-1s way back then. Okay. 2005. Now, the thing is that GLP-1s are helpful. Let's not kid ourselves. This is an amazing tool. GLP-1s are able to give back that control. Okay. But it is a Band-Aid. It's just a Band-Aid. One of the things I don't like about it is that it suppresses appetite. So you actually kind of starve yourself rather than eating properly. So you stop going for a properly formulated ketogenic diet if you increase the dose too much. You're able to tolerate like protein and fat for sure. Okay, fat definitely, but is it helpful in many cases? Yes, and I like to use it many times as a bridge. So that patients have like an easier way of starting the diet, because we're all very addicted to carbohydrates. It's a very, very powerful thing. It's a real addiction, and only sometimes this is a helpful way of starting. Now, then you're stuck on it for life unless you change your lifestyle, and there are consequences to that. Not just psychological, because psychological there are also consequences to being dependent on a hormone. On GLP-1s for life. But my fear is that, it's so important to understand the relationship with food, right? You have power to do this. Something went wrong, let's fix it, right? But instead, it's like something is wrong, let's take a medication. It's like very, it's just another Band-Aid, and like the problem continues to fester. So it doesn't really solve the issue. It doesn't, it because it does lower insulin, by the way, it has some other good side effects as well. So again, it's a medication that works with us. For example, the opposite of insulin that works against us. So GLP-1s are medications that I prescribe. Now, a lot of my patients are on GLP-1 when they come to me. 40% are already on GLP-1s, and they're still obese and diabetic. So it doesn't always work. And when we start the diet, then many times it starts to kick in. The GLP-1 starts to work. So this is something that we see. But GLP-1s, they're not the miracle drug that people think. Now, there are many other things down the pipeline. So there will continue to be other miracle drugs. And, we are a very sick society, but we're kind of just making it sicker by just adding more of these meds and like still, having that gigantic smoothie, with that GLP-1. So there's something kind of sick about it to me psychologically.
So it's not necessarily that someone is morbidly obese that you would, advise them to use that, or is it reserved to a certain type of condition?
I mean,
because what I see here is like as soon as someone has a bit of a weight, they would use it as a normal thing.
Right. So these, it's become kind of also status thing, right? Because these are really expensive drugs.
Mm.
People, and it becomes a socioeconomic gap, really, because the underserved can't afford them. And so it just continues this, this widening gap of health and access, right, to treatment. But again, we I would prefer to. They're like what 30 plus million Americans on GLP-1, and there's a much easier way of treating this whole epidemic. And there's like a giant elephant in the room that we're not doing it. We're not doing this, and
Mm.
instead we're just adding more and more like patchwork to this, and that's not really, in my opinion, the approach.
What are the common side effects that you've seen physiologically speaking?
I've seen a lot of nausea and vomiting. This I've seen a lot of. I have seen patients get depressed on GLP-1 and then get better when you stop it, and then depressed again when they restart. That's 100% anecdotal. So I think the data is out, still not clear on that. I've seen, constipation, because it slows down gastric motility. So that's a very common side effect. Those are the main ones. And then there's the sarcopenia that everyone talks about, like the Ozempic face, etc. Because I think that's more related to malnutrition. That
Because they talk about what 40-50% of muscle mass loss
yeah.
sometimes.
So it varies, but yes, and there's also some evidence of bone loss that I've seen in the study. So it's not a free thing. I mean, I have seen patients with ongoing nausea even after the medication was stopped. That to me is like a very scary side effect. I've seen 2 patients like this. So, there are definitely benefits to it. I would definitely recommend trying to stay at the lowest dose possible.
Mhm. Okay. Um, when it comes to women, how would you say that high insulin impacts women hormones? I guess maybe differently from men. But what would be these differences?
Hmm. Well, insulin leads to, in men, hyperinsulinemia leads to low testosterone. Um, and when we fix the hyperinsulinemia, testosterone can improve. In women, I think it also depends um, on the age. Okay, so one of the driving factors for PCOS is actually hyperinsulinemia. So PCOS is the hyperinsulinemia is leading to the increased testosterone production in the testes, in the ovaries, and and leads to all the symptomatology that we see. I mean, PCOS I think is quite complicated, but insulin does wreak havoc in for women, um, and 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 it's complicated. But regardless, hyperinsulinemia will make, for example, menopause worse. So I really recommend that women take care of this insulin resistance before going through menopause. Then it will be very hard to lose weight, much harder to lose weight with once you lost your.
Can can you quickly explain the mechanisms why hyperinsulinemia would make menopause worse?
Actually, I can't. I don't really understand it fully. I really don't.
Okay.
I don't.
Because I heard many times, sometime women saying, "Oh, yeah, keto, but I can't do it because I need sugar because I'm in menopause."
Yeah, I have to say I don't really understand exactly how that works. Um,
And
so
and I join you on that. I think anybody can feel better, be better in a low carb state. So when a woman says, "I'm in menopause, thus I need sugar," I don't really understand how they get that.
yeah, something is happening at the level of the brain that we don't. understand yet. Or
Mm.
maybe, yeah. So, or maybe we know and I just don't know. Um, but it's not just that. It's also related to how we store fat after. Um, it's not just the cravings, but there's a change in the fat storage patterns in the body. So that's also uh, something that is related to hormones.
Okay. Is the carnivore diet something suitable for most diabetic patients?
I don't see why not.
Okay.
Yeah, yeah. I think it can be extremely helpful. It doesn't have to be forever. I think it's an amazing tool that you can use once in a while. It's hard to do, right? But it's all relative, right? I mean, people think it's hard to eat keto, and I've been eating this way for 11 years. So, it's all, for me, carnivore is something that I do once in a while.
Mm.
If I want to be, I do a reset. I really, I think it's an amazing tool. But I mean, people can be on it and do really, really great for a long time. In fact, I think the carnivore diet has a lot of other uses, not just for diabetes, but I think from an autoimmune perspective, there are many other interesting uses for the carnivore diet. So I think carnivore diets can be sometimes life-saving,
Mm.
very, very, very miraculous. But um, but I don't. Most of my patients have been on it for chunks of time, but not for extended periods of time.
And for that time, they can reduce their insulin.
Oh, yeah, it really reduces their own endogenous insulin. And if you're on insulin, then you will be off of insulin very quickly.
Mhm. Okay. Um, yeah. How would you? That's something also I wanted to ask you. A lot of time, keto is related to a diet, or it's a physiological state, ketosis.
Hmm.
How do you explain the difference to your patient between what is really keto versus just the idea of it's just a diet? Because you find all hundreds form of keto diet.
Yeah, I actually don't. I don't explain that difference. And I also, I don't follow keto. I think that this is more like a way of living. So I don't want to medicalize it so much. This is, even though I told you that this is a medical therapy, because this is like a lifestyle, I think you should just kind of learn. You eat this, you don't eat this, and that's it. So I'm not about like chasing the ketones, and you still get the results. You
Yeah.
get the results by just understanding that no, I'm not having that piece of bread, or I'm having that burger on a plate, and then it just starts to happen. And so I'm not about explaining exactly where your ketone level should be, et cetera, because I don't find that useful in the general population. It might be really useful for like a biohacker, but that's not really the people I'm treating. So I don't you go there.
No, no, that can be complex for most people indeed. Um, but sometimes I feel that people just relate it to a diet and not necessarily to, as you say, a lifestyle and carbs or low carb state. Um, so yeah, I hear some clients, they go, I've done keto. How did you do it? I say, okay, it's not quite keto.
Right, right, right. Yeah, there's so many different ways of doing it, and so many. Yeah, I mean, the goal really is to get enough carbs out so you start burning fat. And to do it in a way that is not. I mean, you can do that by starving yourself, right?
Yeah, exactly.
So that's a very easy way of doing it, but that's not going to lead to the right results. So you're going to be tired and hungry and cranky in no time. So that's basically a low calorie diet. So what you want is to get enough nutrients, and a variety of nutrients in a way that avoids the carbs, and it's really not that much more complicated than that. it's
Mhm.
it's I think it's just a matter of learning a food list, really. this works, this doesn't work, and that's it. And
It's
yes, it can be individualized, and some people are able to eat more than others, and yes, and if you add exercise and you have, all these other things that can make it very individualized results. But the truth is that I think that in a way it's kind of like excuses, like trying to complicate something that's not complicated.
yeah, I see what you say. And in terms of public health policies, what do you think should be the priority when it comes to diabetes and metabolic syndromes?
Well, I really think that people need to know about this option. Okay. I think it's imperative that people understand that this is in their hands. They can feel empowered. They can do something about it. They don't depend on any medication. It's just about what goes into their mouth. That's it. And public health is not doing that. I mean, we started out well with the food pyramid change. That was pretty exciting. This is really, really exciting, but it's not enough. We have a lot of work to do. And we have to really start with the doctors, I think, and really teach the nurses, the dietitians, the doctors, all the people that are treating the patients, that this is an option and offer it as a legitimate option. This is something that to me is absolutely critical.
So, can you tell us more about ONA Health, the platform?
Okay, so OWNA Health is a digital virtual clinic where we treat type 2 diabetes. And the way it works is that doctors are referring patients to us. Patients download an app, and then they get assigned to a doctor as well as a coach. And then they go through a lot of education, and there's a lot of monitoring, and it's a journey. It's a journey. And then 3 months later, they go back to their PCPs, and they're, in a new shape. It's a really fascinating process where we deal with sugar addiction. We deal with, we are particularly focused on the underserved communities. So these patients have 2 jobs, work overnight, always some kind of stress, really big stressors, access to food, and despite all of that, they still do well in many, many cases. So it's a very exciting, for me, this is one of the most exciting things I've ever done. Just helping these patients understand that there's hope, that they don't have to be sick, and giving them their life back. It's really can be a life changer. After this, people start studying or learning new things, or seeing their family members that they have been estranged from for many years. Many things happen down the line that really are a consequence of them feeling better from changing their diet. So yes, it's an app, meaning that it goes through an app, but there are real people behind it. There's a real doctor. It is also powered by AI. There's a lot of AI behind it that is doing incredible things. We can't deny the power that this has in educating, in recruiting, in supervising on many different levels. But yeah, it's human led.
Okay, good. Do you feel that in the process of going into a low carb lifestyle, that the environment, family, friends, can sometimes be an obstacle?
Oh yeah, for sure, for many reasons. Sometimes they think you're exaggerating. They'll come on, like they don't understand the medical part of this. They don't understand this is like a medical necessity. Also, there are cultural things. Most of our patients, from wherever they are in the world, they eat rice. So the patient's like, you can't take the rice away from me. I'm from Bangladesh. And then the next patient is like, you can't take the rice away from me. I'm from Dominican Republic. And I'm like, I don't really care where you're from. The rice is hurting you. Because, but culturally, there's a lot of tension. It's difficult because they've grown up with this their whole life. And like I said, like traditionally, it would have been okay to have the rice. But once you combine the rice with the food in the Bronx, then now I have to take the rice out. So this is and so that there are conflicts with the families over this for sure.
Yeah, sometimes I feel nutrition is worse than religion when it comes to belief. And
Oh yeah, it can really make people excited, angry, upset. It's unbelievable. Yeah.
mm, okay.
And then other times, sometimes if a patient is losing a lot of weight, there's also jealousy, you know,
Oh, you mean
fear, my wife is looking really good, So there are a lot of psychological aspects to this journey.
do you approach them in your practice or in ONA Health as well?
Yeah, lots of times we ask the partner to join.
Mm,
Yeah, I think it's very helpful.
okay. That would be my last questions because I think this is something that I'm very concerned for the future. It's child obesity. What would you say maybe to, because obviously the parents are feeding their children, what would you say to parents when it comes to this issue?
Stay away from sugary drinks. I would start with that. Stay away from sugary drinks, uh, and sugar in general. I think that the big problem here is the fructose, and we have to, and junk food, right, in general. So if we're able to just cut back on one thing, start with what you're drinking. That's like a very nice way to start. So it's overwhelming the amount of sugar in kids' lives. It's overwhelming. It's everywhere. It's so linked to reward, to happiness, to joy. It's a problem. We have a big challenge.
Because I came across some clients who started the keto, low carb, carnivore approach, but then they would tell me, "Oh, I feel so much better. I lost weight, fat mass, and etc., etc. I don't have these migraines anymore. I can sleep better." Okay, um, but I still have to cook a standard diet for my kids. I
Right.
cannot really process that properly as you do something that helps you as an adult by removing the thing that you're still giving to your kids.
I know. Yeah. I mean, ideally, the entire family would switch to a keto diet, but the reality is that there's so much tension around food, that I don't think it's as easy as that. And that's why in this case I say let's go with something very specific to start with, and then take away the fructose, as the sugar. That's
Mm.
really what I suggest. A lot of times I hear that kids start mimicking their parents or start seeing the benefits or are curious, and it kind of depends on the spirit in the house. So
Mm.
it can turn into a very positive thing. I think we have to be afraid, or not, like we just cautious to like make it too strict for the children when if they don't need it. If they're obese already, then that's a different story. But I'm saying, like, in the context of like trying to prevent obesity,
Mhm.
I would just say, you know, it's like decreasing. I'm just thinking about my own kids, and how, um, you know, they understand the theory perfectly well. They can give you a lecture on it. They understand this. They've been when they were like 5 years old, they were telling like a taxi driver what to do because the taxi driver said he was diabetic. My 5-year-old is saying, "You need to stop this." So anyway, but but in reality, I try not to be too neurotic about it for them.
Mm. Okay. Okay, cool. Well, I think we covered a lot when it comes to this specific issue, and you gave us a lot of valuable information on the topic. Thank you very much. I will put in the comment all the links towards ONA Health, and so whoever wants to start a journey and heal properly and regain control,
Mhm.
and you should consult your website.
Thank you. Great. Thank you so much for what you're doing, educating people.
Well, that's not a lot, but at least if the information goes through and helps at least one person, it's already good.
That's all.
Well, thank you very much, Dr. Glandt,
Thank
for
you.
your presence.
And we will, yes, let's stay in touch.
Yeah, thank you everybody for listening. Bye-bye.